us move to the next participant. This is Medical College, Kolkata.
Good evening, sir. 26-year-old male from Diamond Harbour, occupation by newspaper vendor, presented with the palpitation for 2 years, chest pain for 8 months, and shortness of breath for 6 months. The patient was apparently well 2 years back. Then he developed palpitation. It was gradual in onset, regular, with a pounding sensation in chest.
Sorry, age. Can you tell me the age of the patient?
The 26
26 years, sir.
Okay.
Should we continue? Should I continue?
Yes.
Then he developed palpitation. It was gradual in onset, regular, with a pounding sensation in the chest. It was precipitated by exertion and relief with rest within few minutes. Initially, it used to occur during cycling, climbing stairs rapidly, then gradually progressed and occurred during bathing and washing clothes. Later, it occurred even with minimal activity. He had to curtail his daily activity for last 6 to 7 months. This palpitation was preceded by one episode of sudden onset severe chest pain 1 month prior to this over the anterior chest wall. It was stabbing in nature. He went to local doctor after 2 hours of onset of pain and was prescribed some medicine and sent home, but chest pain persisted for 3 to 4 hours, then gradually subsided. There is no history of shortness of breath, loss of consciousness, abdominal pain, or any history suggestive of any focal neurological deficit. The patient also gives history of the intermittent episode of nocturnal chest pain for last 8 months over the precordia without radiation to arm, jaw, or back. It occurred 1 to 2 hours after going to bed. He had to often wake up from sleep due to pain. He used to sit upright and chest pain relieved gradually. It was not associated with shortness of breath. He also developed shortness of breath for last 6 months, precipitated on climbing 2 flights of stairs, relief after taking rest. There is no history of suggestive of the orthopnea or PNB. There is also no history of syncope. It was not associated with any cough or fever. There is no history of leg swelling, abdominal swelling, or decreased urine output. There is no past history suggestive of rheumatic fever or any joint pain, rash, oral ulcer, or eye symptom. There is no history of addiction. Regarding past history, there is nothing is remarkable. Patient is non-diabetic, normotensive, and non-smoker. His appetite, bladder, bowel habit also normal. Regarding family history, his father died at the age of 36 years following sudden onset chest pain. Regarding summary, 26-year-old male with history of the acute onset chest pain followed by exertional palpitation for 2 years, which progressed from the NOIHA class 2 to NOIHA class 3. It was associated with nocturnal angina for last 8 months with exertional dyspnea for last 6 months. There is no history of orthopnea, PND, syncope, or leg swelling.
Does he have any siblings?
Yes, sir. Yes, ma'am.
Does he have any siblings?
Yes. Yes, ma'am.
Because you are giving a very strong, very important history of sudden death in the father following chest pain.
Yes, ma'am.
Yes, ma'am.
So we need to know about his siblings also.
Yes, sir. Yes, ma'am.
Yes, sir, yes.
Yes, ma'am. He has 7 siblings, but none of, according to the patient, the other siblings apparently normal according to the patient. No death in the siblings according to the patient.
How old are they?
Sir, ma'am, patient is our patient is 26 years.
No, siblings.
Okay, ma'am. Siblings age around one sibling is around age 28. Another is 21 year. Another is 16 years, and another is 24 years.
Oh, he has got like 6-7 siblings.
Yes, ma'am. Yes, ma'am.
Okay,
Yes,
so that is important history which you should say because you have a very strong history in the father and in the
Yes,
summary also. In the summary also you should mention.
yes, ma'am. Yes, ma'am.
Okay.
Ma'am, should we proceed?
Yes, tell us your possibilities after the summary.
First, my differential diagnosis for history, it is the aortic regurgitation with a preceding history of query aortic dissection. Next possible diagnosis.
Other possibilities are also RSOV and ACS, though these 2 possibilities are quite uncommon, but still we kept these 2 possibilities. But first possibility is aortic regurgitation with query due to preceding aortic dissection.
So you are saying that aortic dissection of which part? Dissection of which part of aorta?
Ma'am, actually from the history, we can give ascending aorta.
So what is the natural history of ascending aortic dissection? He's had that 2 years ago.
Yes, ma'am. Actually, the aortic dissection involving the ascending aorta, it usually present with sudden onset chest pain, with dyspnea, and also there is increased risk of sudden death. There is also risk of hemopericardium, and also
Very simple question. Very simple question. Very simple question. If 100 patients develop aortic dissection of the ascending aorta, how many will survive for 2 years?
actually,
very less,
20
ma'am.
to 30, 20, around ma'am 20 to 30. Very
No,
less.
I don't think even 20 to 30. Very few. Ascending
few,
aortic
ma'am.
dissection is serious.
Very few.
So why are you trying to put that diagnosis number 1? He survived 2 years.
Actually, ma'am, from the history, and we have got the features of volume overloaded condition.
No, why not
And-
RSOV, madam? Why not RSOV?
Ma'am, the RSOV. In case of RSOV, there is a chest pain followed by this severe dyspnea. But in our case, there is a gap between the onset of chest pain and development of symptom by around 1 month gap. But in case of if it is RSOV, then the symptom usually start with shortness of breath, palpitation immediately after chest pain. So there is also possibilities of RSOV. So we kept in the second possible diagnosis.
How
RSOV
do you-
can it expand? Can it expand the this thing, or the whatever the defect is remains the same?
Sir?
No, you said
Then
RSOV will have
RSOV
the symptoms at the beginning. So is there a possibility that the RSOV, the defect is small initially, and can it become bigger?
Yes, yes, sir. But it is usually common.
The aortic dissection surviving up to this time, the 2 years, and presenting with the chronic symptom is very, very rare. I think don't put it as the first possibility. That is what madam is
Sir,
suggesting.
probably though not common, ma'am, and sir, but there is if there is some chance if aortic dissection occurred and then there is
Why can't-
sudden dilation.
Why can't it be acute AR due to some reason? Some eversion of the valve, some valve damage.
Actually, sir, if it is due to acute AR, then the symptom will start immediately after onset of the chest pain. But here there is a gap between the onset of chest pain and development of the symptom, and the patient gets the symptom of the aortic regurgitation and volume overload symptom. They are gradually increasing from class 2 to class 3. So there is probably the aortic dissection leading to annular dilatation, leading to chance of AR, and AR again there is increasing the annular size, leading to more further increase of AR, leads to vicious cycle. So this is considering these things, we kept this in the first process.
Yeah, I think that is a reasonable explanation that she's giving. Because there is a possible, I agree that these people will die very, it could be catastrophic.
Yes.
But sometimes you just have the dissection, and well, that is also catastrophic. But you have the
So you-
dissection, and then
Is there
over time AR develops. So
Is there
I
any
think-
other possibility associated with
No, but
aortic dissection?
Sorry, I had one question.
Is there any other
How-
possibility associated with aortic dissection which can present it slightly later? Can it be associated with some form of ischemia?
Yes, sir. Aortic dissection can cause ischemia and chest pain if aortic dissection involving
No.
the
Coronary
Coronary
Which coronary?
usually
Most-
commonly right coronary artery is commonly involved.
Okay, can that present with the later symptom?
Yes, sir. Yes, sir. Sir, please, sir.
No. Can that involvement of the right coronary present with a symptom of later onset?
Sir, if there is involvement of the right coronary, that ultimately may lead to ischemia, and there is involvement if due to ischemia, there may be involvement of the papillary muscles and volume overload condition, mitral regurgitation, all these possibilities are.
Right coronary leading on to papillary muscle dysfunction.
How does your family history, that history of sudden death at a young age in the father, how does that relate to any of these three possibilities? Can you link family history to any of these possibilities?
Okay, sir. As his father died at age of 36 years.
That is very unusual. No?
So there are the different possibilities. Coronary artery disease, though the age is less 36 years, and the other possibilities are probably aortic dissection, and also another possibility we can keep HOCM, but there is a history of chest pain. So sudden death can occur in a case of HOCM due to arrhythmia, but chest pain is sudden onset chest pain with patient died is uncommon. So possibilities of ACS and also possibility of
Is aortic dissection familial?
Yes, yes, sir. It can be familiar, sir.
Yes. Okay. Is RSOB familiar?
Sir, not common, sir. Though it can be RSOB can be, but not common.
I don't agree with you. RSOB is not familiar.
I think dissection is probably, you could have.
Dissection has some familiar, but if you want to take that history, then ACS should be your first diagnosis, because that's the most likely familiar. Young MI happening, young MI in father, and then young MI, maybe because of some, homozygous hypercholesterolemia or something like that. But of the three diagnoses that you made, the most plausible familial would be ACS.
I think they have made clinical features of aortic regurgitation in the history.
Yeah, absolutely.
So
absolutely.
aortic regurgitation, the runoff is there. They have volume load features, exertional palpitation. So I think we have to make a diagnosis of aortic runoff. Means
aortic runoff for sure, and therefore it doesn't fit with ACS. So I agree with that. Only thing is that if you are thinking of familial something, then ACS would be very important. But since all these other siblings are fine, I would probably think of something else. But still, between dissection and RSOB, I would choose RSOB as one, dissection as number two.
Okay, let us move forward then. Examination.
Regarding clinical and general survey, patient is conscious, alert, cooperative. Pulse is 84 per minute, regular, high volume, water hammer type, no radioradial or radiofemoral delay. Pulse palpable equally in all four limbs. There is a prominent suprasternal pulsation with bilateral carotid pulsation. Dirogeous murmur is present. Regarding BP, in right upper limb it is 120 by 54. In left upper limb it is 122 by 54. In left lower limb systolic BP 160 and right lower limb is systolic BP 158. Regarding respiratory rate, it is 20 per minute, abdominal thoracic, saturation 98% in room air.
Just interpret this BPs. You told us 4 blood pressures. What do you want to tell us? Give me the hemodynamics of this. This is normal, abnormal. What do you want to tell?
Sir, from this blood pressure, there is a pulse pressure is high, and also, sir.
And
there is pulse pressure is high, and also there is systolic blood pressure in lower limb is more than the upper limbs, and there is the hill sign is difference is approximately 40, and so hill sign is a significant positive sign.
You said you say high volume.
Suggestive of a high, yes, sir, high volume pulse.
What is the blood pressure?
Sir, right upper limb blood pressure is 120 by 54, left upper limb 120.
Yeah, 120 and the high volume pulse.
You think this will produce high volume pulse or it will not produce high volume pulse? 120 by.
Sir, please, sir.
The blood pressure of 120 by 54 will produce a high volume pulse, or it will not produce high volume pulse?
High volume pulse.
What does the volume of the pulse relate to?
Pulse pressure is the high.
Pulse pressure is fine. Pulse pressure is high.
Pulse pressure.
Pulse
pressure more than 60.
Okay.
Saturation 98%, room air, temperature not raised, pallor, cyanosis, clubbing in icterus edema is absent, JVP not raised, normal wavefront, hepatojugular reflux is absent.
This is the anthropometric measurement showing height 177 centimeter, weight 51, BMI is 16.3 kg per meter square, arm span is 190, and upper segment is 81, lower segment is 96, upper segment by lower segment ratio is 0.84, that is less than 0.85, and arm span is more than height, and the ratio is arm span and height is 1.707. And this picture showing there is the arachnoidactyly is present and positive wrist sign and thumb sign, and there is a pes planus deformity.
Did you ask whether his father was also like him?
Yes, ma'am, I have asked, but according to the patient, his father is also a tall stature and like this, but exact he cannot tell. But according to the patient, he is also like this.
And his siblings?
And he also tells that some siblings are among 7, 4 are like him. Not all, 4 are like him, tall stature and all these things.
Okay.
So 4 siblings are tall like this.
Yes, sir.
Okay.
That was a very important family history that you missed.
Ma'am, I have asked, but I have written in the letter in the family screening page. I have written.
No. In the family history, when you talk of history, you don't examine. History means history.
Okay.
So you should have, if you asked, you should have said that you did not tell us about certain death. These are very, very pointers in the history that could have taken you to the diagnosis immediately.
Okay, ma'am. I have actually mentioned in the later slide. I have mentioned, ma'am.
When you okay.
Okay, go ahead.
Previous examination, inspection, palpation, there is a apex is left second intercostal space 2 cm outside the mid-clavicular line. It is forceful, ill-sustained, LV type. There is a prominent pulsation over the right second third intercostal space, parasternal region. There is no obvious chest wall deformity or no scar mark is present. On auscultation, S1 is normal, A2 is loud, P2 normal split, LVS3 present, S4 is absent. There is a decrease in the high pitch blowing early diastole murmur over aortic area, occupying more than 50% of diastole, base 13 right second intercostal space in sitting and leaning forward position with diaphragm of stethoscope. There is a ejection systolic murmur over the right second intercostal space, early pricking, grade 3/6 in sitting and leaning forward position with diaphragm of stethoscope. Other system examination, chest, bilateral vesicle. Yes.
Yes,
Chest examination, respiratory system is a bilateral vesicular question is there is no crepitation. On GI system, liver spleen is not palpable. Nervous system, there is no focal neurological deficit. So my provisional diagnosis is the severe aortic regurgitation with aortic root dilation, patient in Marfanoid habitat with mild PVH, no PH clinically, without feature of congestive cardiac failure, NOH a class 3, sinus rhythm, without evidence of infective endocarditis.
Did you tell about his eye examination?
Yes, ma'am. It has
Normal?
Ma'am, latest slide. Ma'am,
Sorry?
Ma'am, in latest slide, ma'am.
It percent ectopia.
Next slide, ma'am. Should I
No,
proceed?
this is your diagnosis, bhai. How can you have examination after diagnosis? What was the eye examination?
Yes, ma'am. Eye examination was done. Should I proceed?
But what did you look for? What did you look
Ma'am,
for?
this is the eye examination was done. Patient was taken to the for slit lamp examination. Eye examination.
No. I'm not talking of ophthalmologist examining his eyes. I'm talking of you examining his eyes. Did you look for something in his eyes or
Yes,
you
ma'am.
did
Yes,
not?
ma'am. I have searched for iris stimulations, but we cannot find any obvious eye.
What did you look for?
What did you do? What examination did you do? What did you use to examine?
For lenticular dislocation and iris stimulations.
Did you look for his vision? Did you test his vision?
Myopia is not there, ma'am.
Sorry?
Myopia is not.
No, I'm asking you, did you test for vision? Myopia, I'm not asking myopia.
Ma'am,
Did you
no,
test his
yes,
vision?
yes, ma'am. Yes, ma'am. Vision.
It's
But there is-
normal. Vision
yes.
is normal.
Yes, ma'am. There was no obvious defect. Normal.
Okay. Once you made a diagnosis of marfanoid habitus, you have
Yes,
to do preliminary eye examination by you, not by ophthalmologist. I don't want to see these images. You can take them off. That's investigation.
Acha,
We
okay.
want you to tell us, was there any evidence of vision problem? Was there any subluxation or not?
Okay, ma'am.
Clinically, by you.
Okay, ma'am. Okay, ma'am. Okay, ma'am.
Was it there? Go to your physical examination slides.
I don't think they have mentioned
Go back.
that.
Go
No, no,
back. Where
the-
you are describing the marfanoid habitus. Before that, what about his eyes? See, once you have diagnosed somebody having marfanoid, still you don't want to look into the eyes. That's not done.
And that is I think that is a gross. What is it? I think you should do that. Otherwise, it will be a problem.
But did you ask him what is he doing? What is his occupation?
Ma'am, newspaper vendor, ma'am.
So does he read newspaper?
No, ma'am. He not regularly read newspaper.
If you didn't ask, you didn't ask. Don't try to make it up. So if he, how much has he studied? How much has he studied for? How many classes?
Sir, 8. Ma'am, 8.
8. So he should know how to read and how to write, isn't it?
Yes, ma'am.
So you should ask him if it, see, I'm not saying you do it in every case, but once you have checked for marfanoid habitus, it's mandatory to talk of skeletal abnormalities, spine, eyes. You have to talk of those things. Otherwise, how do you diagnose somebody is having Marfan syndrome? You will keep saying marfanoid. You will never be able to make a diagnosis of Marfan's then.
Okay, ma'am.
Did you do the upper segment, lower segment?
Yeah, they have done
Yes,
that.
sir.
They have done. Okay, yeah. Okay. I missed that. Sorry. Okay.
Okay, so go to your diagnosis now. See, where you have written other systems, just before this, it should have included eye examination. It should have included skeletal examination for any spinal deformity.
Okay, ma'am. Okay, ma'am. Okay, ma'am.
Okay, so this is your provisional diagnosis. You are still calling it marfanoid habitus. Why do you not want to call it Marfan's?
Because, ma'am, okay,
Now, how will you diagnose Marfan syndrome?
cardiovascular examination and eye examination kept in the later slide, so that's why I kept.
Madam, this is provisional diagnosis based on your history and clinical examination. Forget
Ma'am,
about later slide. There is no later slide.
Ma'am, from history and examination, there is on examination there is features suggestive of skeletal features suggestive of Marfan's, and also there is a history of family history of Marfanoid.
Okay, let me ask you a theoretical question. How do you differentiate between Marfanoid and Marfan's?
Ma'am,
When do you say somebody having Marfan syndrome? What is the definition of Marfan syndrome?
Ma'am, for Marfan syndrome, we have to fulfill the criteria in presence of family history. If there is in presence of family history and in absence of family history, in presence of family history, if there is presence of aortic dilatation and ectopia lentis, or if there is presence of aortic dilatation with 7 systemic features or skeletal features, or if
So
there
your
is
patient has it.
lentis,
Your patient has it. Your patient has 2 out of 3. Forget about ectopia lentis. You didn't examine for that, but you have the skeletal features. You have the clinical examination of severe AR. Why you still writing Marfanoid? I don't understand.
Actually, ma'am, aortic dilatation, actual measurement,
See, that is the problem, no? That is the problem. You people have gone too much into investigations. You don't want to make any diagnosis clinically.
Okay, ma'am.
I would say Marfan syndrome, you have skeletal problems, deformities.
Okay,
You have aortic regurgitation, which is severe from what you have written. What else do you want? I don't understand. I mean, you really want an echo?
Yes, ma'am, for measurement of aortic.
No, sorry. Your Marfan's has to be
See,
diagnosed clinically.
See,
Okay,
if
ma'am,
you
okay,
have
ma'am.
if you have not done something, better to accept that you have done something. Don't try to argue and go into other issues. They will go and ask more and more things. So better to accept that we have not done and accept
Okay,
that.
ma'am.
That
Okay,
is a
ma'am.
better
Okay,
way.
ma'am. Okay, ma'am. Sorry, ma'am.
I think you are trying to justify whatever you have presented or something. I don't think it will do good in the exam.
Okay.
So try to
Okay, ma'am.
accept your
Okay,
shortcomings
ma'am.
and go with that.
Sorry, ma'am.
Yeah.
Okay. So it is Marfan syndrome with severe AR, with mild PVH, no PAH, without features of CCF, NYHA class 3, sinus rhythm, without evidence of infective endocarditis. Okay. Can you talk about LV function?
Ma'am, from the history, there is shortness of breath for NYHA class 2 for last 6 months, and so there is possibility of mild LV dysfunction if they are mild LV dysfunction.
And
No,
what
do
was the
you-
chest
no, no,
pain due
that-
to? What was the chest pain due to? That is not defined in your diagnosis.
Sir, ma'am, chest pain was for last 8 months. Chest pain is
No. Initial chest pain, acute chest pain that he had.
Oh, acha. Initial chest pain was due to aortic dissection, ma'am.
Kahan hai? Diagnosis not written.
Okay,
So
go to the-
you see, dissection is a very important part of your history. That's what you are thinking, that AR has happened secondary to dissection because of the severe chest pain that he had initially. Remember, he had chest pain, severe chest pain.
Yes, ma'am. It has been missed, ma'am. Actually.
So if you are thinking of dissection, you must, even if with a query, if you want to write, you can write query dissection ascending aorta, but please
ma'am.
mention that. Otherwise,
Yes,
you
ma'am.
have forgotten about that chest pain completely.
Yes, ma'am. It has been missed.
And it is important because he might have a dissection again if you don't
Yes.
mention it. Okay.
Show your investigation.
Ma'am, investigation done, chest X-ray shows there is increased CT cardiothoracic ratio and there is dilatation of the aorta.
Which part of aorta?
Dilatation of what
No.
part of aorta? That you should
Ascending
tell. No.
aorta.
Dilatation of the aorta means
Dilatation of the ascending aorta.
what about descending aorta? Is it normal or seen or?
Sir, normal descending aorta.
Okay. So what else is there? What do you say? You said the patient had dyspnea. Is there any PVH? Is there any LV enlargement? All those things you have to say.
Sir, CT ratio, cardiothoracic ratio is increased. There is no gross obvious vena, no significant venous pulmonary venous hypertension from this X-ray.
Okay.
Is there dissection?
Ma'am, from this X-ray we can see that there is dilatation of the.
How do you diagnose dissection? And how do you differentiate it from dilatation?
Ma'am, in case of dissection, usually there is we can see the defect actually, ma'am.
On X-ray?
On
You
No,
won't be
ma'am,
able to
on
see.
echo. On
No, we
echo.
are talking of X-ray. No, we are not gone to echo. We are saying on this X-ray, can you suspect that this child or this patient may be having dissection? Or you cannot? That is the question.
Ma'am, corroborating with the history.
X-ray, ma'am. Tell me the X-ray. Ma'am is asking on the basis of X-ray. Tell me yes or no. तुम लोग straight answer करने की कोशिश
No,
जानने की
sir, no, sir.
No.
No.
Sometimes chronic dissections can show you calcification. So you may see a calcified line within this shadow. You have to look for it. It happens very rarely, but you have to be aware of it. You have to look for it. If you don't know, you will not look for it.
Okay, ma'am.
Okay, go ahead. I would say aneurysmal dilatation of aorta, not just dilatation, aneurysmal dilatation of ascending aorta. Okay.
ECG showing the sinus rhythm, and there is features of LVH and ECG precordial, actually precordial taken in half standardization, and there is fulfilling the criteria of LVH.
Axis?
Axis, ma'am, 30 degree.
Okay. So you think there is LVH with strain?
No, ma'am. There is the LV volume this is the LV volume overload condition, ma'am, from this ECG.
So why ST is depressed in V5 and V6? Is it depressed or not depressed?
Mildly depressed.
See, remember, this is half standardization. What you're thinking mild may not be mild.
No, what is the mild,
Standardization is-
moderate and severe depression? Tell me. तुम लोग neologism मत इस्तेमाल किया करो. What? How will you define a ST depression in ECG? So you have to be very, as at DM cardiology level, you have to be very particular. Never say mild depression, moderate depression, severe depression. There is a definition given for our thing. Okay, go to next.
Examination under slit lamp examination, there are lenticular coloboma, inferior aspect with inferior nasal subluxation. This is the inferior coloboma in this eye, and this is the inferior coloboma.
So even with all these things, his vision was normal according to you.
Yes, ma'am. Yes, sir.
Okay, okay. Yeah. Go ahead, go ahead.
Go on, go on.
Echo
ahead,
was
yeah.
done. This picture echo showing there is intimal flap in this aorta, and there is dilatation of the aorta, and it shows there is dilatation at the level of sinus of pulse of the STG and ascending aorta, and there is also development of aortic regurgitation and intimal flap is seen, and there is hollow diastolic. This picture showing hollow diastolic flow reversal, and this side picture shows there is LV dilatation and approximately LV-IDD 70, and there is LV-EF approximately 47 to 50% around. This picture showing there is eccentric closal line, and there is dilatation of the aorta and eccentric closal line, and this side picture showing there is bicuspid aortic valve. Video showing aortic valve, and this
Shows
is
the valve, because I'll be very surprised. Marfan's with the bicuspid aortic valve.
yes, ma'am.
Where is the bicuspid aortic valve? This is
Ma'am.
dissection. This is dissection.
Ma'am, this side is dissection, and this
So have you heard of bicuspid aortic valve and Marfan syndrome?
ma'am, in this picture there is also suggestive of eccentric closal. Huh, ma'am?
I think what
No,
that
these
is-
are flaps. These are dissections.
Yes, these are
These are
flaps.
all very difficult to say eccentric closure and all with this dilated aorta and with this
Right.
dissection.
No,
I
with
think
so
very,
many
very
dissection
erroneous
flaps,
to
how
go
can
with that.
Ma'am, this is dissection flap, and this horizontal, ma'am, this opening is bicuspid, and this
Madam, you were just told by Dr. Hari Krishnan
is okay,
that
ma'am.
you have to sometimes accept what we are saying. I'm not saying you blindly accept it, but if you keep arguing, then there is no learning here.
Okay, ma'am. Okay, ma'am.
No, again, don't accept it just because I'm saying. But please have your eyes open and listen to what we are saying, and again look at it. I'm not saying you change your mind. I'm saying don't be close to what suggestions we are giving.
Yeah, go
So
ahead.
please have a look again.
this is at
Please.
the aortic.
Yeah. Please,
This
Dr.
is at
Goel,
the-
go ahead.
Yeah, this is at the aortic valve level that she's trying to show. Actually,
See, the trouble is that
this
the
entire thing is
dissection
not
flap
valve. This entire thing
Ah.
is not valve. This is
because the dissection flap is coming very close to the valve, so you may not be able to see. That is all we are saying. So
Yeah.
don't be so dogmatic about it. It may not be bicuspid. We are just telling you that. We are not saying you accept what we are saying.
And we have exceeded about 10 minutes.
Okay, we'll stop then. Yeah. Okay. Anything else we have here? Otherwise, we'll go to the management.
Ma'am, CT autogram was done.
You have the pictures? Do you have the pictures?
CT
of
autogram. Oh, yes,
CT
ma'am.
pictures? Okay, let's look at the pictures and you
Ma'am.
can interpret them quickly.
Ma'am, CT autogram shows there is dilatation of the ascending aorta, and there is
What additional information are you getting from CT which you did not have on echo?
ma'am, from extension of the
Yes. So till where it is extending?
Ma'am, from it extending from the this ascending aorta from the aortic leaflet, and in this part there is showing dilatation of the ascending aorta, and there is intimal flap, and this picture showing there is flap extending up to the arch of the aorta, and this portion is the false lumen, and this is the dissecting flap, and this picture there is also showing there is dilatation of the aorta and the dissection flap extending here from up to the origin of the left subclavian artery. This picture taking on the from the back side 3D reconstruction image, still image showing the plane of the dissection dissecting flap.
So why high blood pressure? Why his blood pressure is not different in the two limbs?
Yes, ma'am. CT report, though the dissecting flap extending up to the origin of the left subclavian, but the report shows that the origin of the arteries are normal. Maybe the dissecting flap involving the other plane, not the same up to the ear, but flap or orientation of the flap involving the that plane that it cannot involve the origin.
What do you mean by normal and involve the origin? What is all that? What is? Can you tell me technically in radiological terms?
Ma'am,
What is it?
Sir,
Normal means what? I understand what you're saying. So it is normal means.
sir,
What is a true lumen? What is a false lumen? That can you explain that?
yes, ma'am.
You understand the concept of true lumen and false lumen in the dissections.
False lumen is dissecting flap that separates the aorta, and there in the false lumen there is the blood flow from the aorta is separated, and there if the true lumen site, then the there may not be involvement of the vessels, and blood pressure may remain equally in the if it is the site of the flap depend upon the site of the flap. If vessels originating from the true lumen, that it will not
Even in false
significantly affect the
lumen,
blood flow.
no, you're wrong. Even in false lumen, the blood pressure may still be okay, but you have to understand. You have to see it on a frame by frame cut frame on the CT.
Yes.
And true lumen, if it's coming from the true lumen, it is fine. It's coming from the false lumen, then that artery gets closed if you repair the thing, the dissection.
Actually,
So you have to understand that.
Yes, sir. Yes, sir.
Yeah.
But what will you do for this patient? Because we don't have time.
So from this final diagnosis, type A aortic dissection with severe aortic regurgitation with bicuspid aortic valve with dilatation of the root of the aorta and ascending thoracic aorta in case of Marfan syndrome, and there is mild PVH, no PH, without features of CCF, NYHA class 3 sinus rhythm without infective endocarditis. This patient was then underwent dental procedure. Yes, sir.
Patient underwent. He's already had the procedure.
Yes, sir. Yes, sir.
Okay.
So your findings were prior to surgery, I presume.
Because you won't get those findings now.
You examined before surgery.
Yes, ma'am. The patient was admitted in our ward. We diagnosed, and then we sent this patient to surgery. And after surgery, we asked the patient for follow up, and also we have some follow up.
So what are his findings now? What are his findings now?
Yeah.
After surgery, ma'am.
Yes, yes.
Ma'am, this is the post of echo after surgery.
No. Clinical findings.
Ma'am, after surgery, his blood on examination, there is blood pressure is around 116 by.
I think we are exceeding time.
Yes, ma'am.
What was done for the
after surgery? Is there any hemodynamic? What is the hemodynamic status? Is there AR?
Yes, ma'am. There is on auscultation. There is no AR, and there is also metallic sound on the cardiovascular system examination, and there is no AR.
Only my advice to this group is that I think
he has a prosthetic valve. Which valve is it?
Sir, it was there was conduit valve, mechanical chain root conduit valve aortic root replacement was done. and with the insertion of the coronary artery.
Okay. So my advice to this group is that just listen to the examiners. If you have made, if some shortcomings in the history or anything, just try to accept that rather than going on arguing and getting away from.
Because you see, the purpose here is we also want to tell you what could be the right approach. You understand?
I think
So
this
you
is
should
also
depend
it's also a way of learning. So
this is more of a teaching session than an exam, truly. You understand? Okay, I think we should go to the next case then.
Next case, sir.
And this is post-op X-ray and this is post-op echo.
Okay.
Fine.
And this is the
We go to the
family
next
screening portion, ma'am. Among these are of having Marfana asked them for OPD, regular OPD follow-up. And this is thank you, ma'am.
Good.
Thank you, ma'am. Thank you, sir.
The last case is from AIMS Rishikesh.
Yes, sir.
You start sharing your screen without any further delay. You start presenting your case.
Yes, sir. Mr. Rahul Singh, 30-year-old male, Hindu by religion, resident of Moradabad, UP, farmer by occupation, studied up till 5th standard, married, history given by patient himself and seems to be reliable, presented with the chief complaint of chest pain since 1.5 months, dyspnea on exertion since 1.5 months, and palpitations on exertion since last 1 month. Patient was in best of his health 1.5 months back. While doing farming activity, cutting sugarcane in his farm, he experienced sudden onset, severe retrosternal chest pain, stabbing in nature, radiating to back interscapular region, not relieved by a rest, and lasted for an hour. His pain spontaneously reduced and became episodic to mild pinpricking type till he presented to us, and it was not aggravated with exertion. Pain was not associated with diaphoresis, no episode of any loss of consciousness or perspiration. There was no preceding history of vomiting, retching, or chest trauma before the pain. Pain was also associated with difficulty in breathing, which was sudden onset, which led the patient to discontinue his work. The dyspnea was even present when patient took rest. Patient found difficulty in lying down and was more comfortable in sitting position. Patient consulted locally for the same and took some herbal medications and stayed at home for a week. Patient confined to himself to the bed, and his chest pain and dyspnea improved, and patient was comfortably lying down and doing routine household activities for a week. 1 week later, he resumed his activity in the farm. However, he was getting breathless while walking to his farm, which he used to walk without discomfort before this event, suggestive of NYHA class 2 dyspnea. He used to take rest and then used to resume his activity. However, since past 10 days, his breathlessness has increased to such an extent that he gets breathless even on his routine activity like going to washroom or bathing, suggestive of NYHA class 3 dyspnea. This breathlessness was associated with difficulty in lying down, and he had to use 2 pillow supports to make himself comfortable in night. There was no associated history of paroxysmal nocturnal dyspnea, no history of cough, wheezing, or hemoptysis, no history of weight gain, no pedal edema, no increase in abdominal girth. Along with dyspnea, he also complains of palpitations on exertion for last 1 month, which was insidious in onset and occurred only on exertion and relieved by taking rest. And the palpitations were not associated with dizziness or any loss of consciousness, and also not associated with post-palpitation diuresis. In negative history, there was no history of fever with chills or abdominal pain, no history of any limb swelling, no history of oral or genital ulcer, joint pain or hair loss, no history of headache, confusion, delirium or weakness of any limb, no history of decreased urine output, no history of tuberculosis, and no history of any sexually transmitted disease. In the past history, there was no history of hypertension, diabetes mellitus, no history of any systemic illness in the past, and no history of prior admission to hospital. Personal history, he is married with and father of 2 children, vegetarian by diet, having altered sleep and appetite for past last 1.5 months, normal bowel and bladder habit, non-smoker, non-alcoholic, no other history of any substance abuse, and no high risk behavior. Family history: he is fourth by birth order and has 2 elder brothers and 1 sister. All are doing well. No history of sudden cardiac death in family. No history of any cardiac illness in the family, and no history of similar illness in the family. His socioeconomic status is he lives in a pakka house, belongs to upper middle class as per modified Kupuswamy socioeconomic scale. Treatment history: since admission to the hospital, he received some IV and oral medications, and his symptoms has improved. He is comfortable in lying down and walking till washroom presently. Coming to the summary, he is a 30-year-old male with a sudden onset severe retrosternal chest pain 1.5 months back, which associated with sudden onset rapidly progressive dyspnea on exertion, which was NYHA class 4 to begin with, and had a transient improvement, followed by which worsening of the dyspnea to NYHA class 4 again over a period of 1.5 months since, and he is in NYHA class 4 since past 10 days with the associated history of palpitations on exertion since last 1 month. So coming to the possible, yes, sir.
Go back.
Yes, sir.
So how do you hemodynamically or conceptually, how do you explain what is happening? Can you tell us?
Yes, sir. Sir, basically, there is an episode of severe retrosternal chest pain, after which he has a symptoms
Yes,
of
retrosternal. I agree. No. History, I understand. So retrosternal chest pain. What? It is ischemia. It is. What is? What do you think about it?
Yes, sir. Likely ischemic chest pain, sir. Yes, sir. He had an episode of chest pain, probably.
And then after the chest pain, these symptoms which are there.
Symptoms of volume overload, sir. Dyspnea and palpitations.
Volume overload.
Yes, sir.
What is in your mind?
Sudden onset of acute volume overload, sir.
Ischemic chest pain chest pain followed by sudden volume overload. What is in your mind?
Sir, most the common differential for this is acute coronary syndrome. With it may be a large extensive anterior wall MI with acute LV dysfunction causing this LV dyspnea and as well as
where is the volume overload?
Sir, LV volume overload, sir.
Due to?
Sir, it may be because of ACS leading to acute MR, sir. Transient MR that has caused the sudden onset of orthopnea.
Transient MR.
Yes, sir.
So you say this acute MI complicated, acute myocardial infarction complicated by acute MR. That is your thought process.
Yes, sir. First differential is this, sir. However, because of the chest pain which lasted for an hour, and after that it is pinpricking types only, with the significant history of dyspnea and palpitation, it can be aortic dissection with the acute aortic regurgitation. Another possibility it may be, however, there is no history of fever, which is very unlikely. However, it can be there in case of infective endocarditis, and because of that endocarditis, there is a perforation of the cusp that can also lead to valvular regurgitation. Another possibility is a ruptured sinus of Valsalva, which presents with this chest pain and palpitation dyspnea with a short history, and very unlikely, but it can be there as patient is a 30-year-old male without any history of hospitalization or immobilization or any limb swelling. However, because of any hypercoagulable state, there can be an episode of acute pulmonary embolism causing chest pain, as well as the DR, so volume overload in the.
You said the age of the patient is 30, no?
Yes, 30 years, male.
30-year-old without any risk factors. Why did you put the acute myocardial infarction as the first possibility?
Yeah.
And because the young coronary artery disease is very prevalent, sir, nowadays, sir.
You have data to show that coronary artery disease is there and increasing in India. What data?
Sir, sir, in the inter-heart study, they have mentioned that
Which study? Which study?
So the inter-heart study, sir.
Inter-heart study. Okay.
Yes, sir. They have mentioned that in the Asian populations, Asians and African populations, the young CAD less than 50 years of age, the prevalence is nearly 12 to 16%, sir.
What percentage?
12 to 16%, sir.
Less than 50 years. Inter-heart study. Inter-heart study.
Yes, sir.
Okay. You may be right. I don't know. So 30-year-old, but I would put the possibility as very, very low. 30-year-old without any risk factors developing a. Is it following an acute? Strenuous exercise?
Sir, he routinely do the activity in the farm.
This particular episode, was it associated with an acute severe strain?
Yes, sir. He was doing strenuous activities.
So then what is the possibility then? Rather than atherosclerotic coronary artery disease, what is the possibility? I agree, ischemia and acute MI. What is the possibility?
It can be a aneurysmal sinus of Valsalva, which because of the physical.
No, ischemia only. Related to coronary, what can it be? Can it be coronary artery dissection?
Coronary artery dissection, yes, sir.
Yeah, okay.
Yes, sir.
And why can't it be acute MR and some papillary muscle, caudal rupture, and why can't it be an MR, acute MR? In age, he may be having previously existing mitral valve prolapse. Why can't it be an acute MR with a caudal rupture?
Sir, because of ischemia, sir, acute MR, sir. He had no history of, sir, any chest pain.
These are all mitral valve prolapse, need not have much history. No, he must have some chest pain or something like that. Is it a possibility?
Yes, sir, it can be a possibility, sir. But because he had a transient improvement in his symptom after an hour of the episode, and then again progressed gradually from NVK class 2 to 4 over a course of 1 month. So this.
So which among the things can have an acute improvement? You said acute myocardial infarction with MR, acute aortic dissection with the AR. So why does all these three possibilities that you have put can have a transient improvement? Because you said that is one possibility against mitral valve prolapse and caudal rupture. Why should these three things have an improvement in between?
Sir, in case of acute MI, sir, as the pain settled and the patient had an transient MR and then he developed LV dysfunction. After a few days, he stabilized, and then he is now having a history of CAD with the LV dysfunction and gradually progressing dyspnea and palpitations. In case of, sir, acute aortic dissection, he might have a intimal tear at the ascending aorta that extended to the aortic cusp and caused the AR. And in a day,
why should he improve? Why should he improve?
Sir is asking why should they improve? All the three conditions you are enumerating 1, 2, 3. Why they will improve? What is your point?
You said they have a significant improvement. Why should they improve?
Sir, basically, sir, he after that episode, he with what he routinely used to do, go to the farm and do his activity. He stopped himself from all those activities and preferred to stay at home only because of this episode. So it may be possible that he might feel all the symptoms. However, because he restricted himself a lot as compared to what he used to do previously, so he felt it better.
That is say applicable with MVP with MR also, no? With caudal rupture.
But sir, acute MR of such an extent will.
You said this acute MI with MR also will have the same. Okay, go forward.
I think go forward. Yes.
Sir, coming to the general physical examination, patient is conscious, cooperative, well oriented to time, place, and person, alert and responsive. Pulse rate 90 per minute, regular, high volume, water hammer in character with no radiofemoral delay, condition of vessel wall normal, and all peripheral pulses were palpable. Blood pressure in right arm, it was 130/40, in left arm 128/42. In right lower limb, it is 150 systolic, and in left lower limb, it is 154 systolic, with a wide pulse pressure of 90, is there, sir. Respiratory rate at 20 per minute, abdominal thoracic, regular, without use of any accessory muscles. His saturation is 98% on room air in all the digits. JVP 5 centimeter above the sternal angle with a prominent A wave. No pallor, icterus, cyanosis, clubbing, pedal edema or lymphadenopathy. Height is 160 centimeter, weight 50 kg, BMI of 19.5 kg per meter square, which is normal. Upper segment to lower segment ratio normal. His arm span 150 centimeters, so arm span to height ratio is also normal. He is afebrile. He also has peripheral signs of wide pulse pressure, Corrigan sign, Quincke's sign, Dorizin murmur, and pistol shot femoral. Skin.
What is his RA pressure?
Sir,
RA
yes,
pressure?
sir, JVP is 5 centimeters above the sternal angle, so RA pressure will be 10 centimeter of water,
Okay.
or 7 mm of Hg, sir, 7.3 mm of Hg.
Okay.
Skin, skull, spine normal, no marfanoid habitus, no signs of infective endocarditis. Fundus examination has no Roth spots and no other abnormality. On cardiovascular examination, sir, in inspection, chest was bilaterally symmetrical. Apical impulse is seen one space below the nipple, lateral to mid-clavicular line. No other visible arterial pulsation, veins, scars, or sinuses. On palpation, findings of inspections confirmed with the apex beat in 5th intercostal space, just lateral to mid-clavicular line with medial retraction. Hyperdynamic in character, LV type. Palpable systolic thrill is present in left 5th, 6th intercostal space. Grade 2 left parasternal pulsation and palpable P2. On percussion, left heart border corresponds to apex, right heart border is retrosternal, liver dullness in right 5th intercostal space, gastric tympani in the left side, and second right intercostal space is resonant. On auscultation, sounds S1 is normal, S2 loud, P2 with the normal splitting, LV S3 was present. In murmurs, there was a harsh, high-pitched, continuous murmur, grade 4/6 with systolic augmentation, best heard in left sternal border in 4th, 5th intercostal space, radiating to right parasternal border, best heard with diaphragm of stethoscope. Another, a low to medium pitched rumbling with diastolic murmur heard at apex with the bell of stethoscope at the end of expiration. Other systems, respiratory system, bilateral vesicular breath sounds with no added sounds. Per abdomen was soft without any hepatosplenomegaly. The liver span was 11 centimeter and CNS was normal, sir. So coming to this, sir.
Summarize the findings. Summarize the findings.
Describe, just read the murmur again. The murmur, can I?
Yes, sir.
Yeah.
So, once a harsh, high-pitched continuous murmur of a grade 4/6 with systolic augmentation, best heard in left sternal border in 4th, 5th intercostal space, radiating to right parasternal border, best heard with diaphragm of stethoscope. And another low to medium pitched rumbling mid diastolic murmur heard at apex with the bell of the stethoscope at the end of expiration.
Okay.
So this summary, sir, he is a 30-year-old male, farmer by occupation with a significant history of sudden onset severe retrosternal chest pain of before 1.5 months, with the history of dyspnea on exertion, which was NYHA class 4 to begin with, and after a week progress from NYHA class 2 to class 4 over a course of 1 month, and a history of palpitations on exertion and NYHA class 2 with a pulse of 90 per minute with a wide pulse pressure and elevated GVP with the peripheral signs of wide pulse pressure, along with LV type of hyperdynamic apex in the 5th intercostal space, with a continuous, harsh, high-pitched continuous murmur of grade 4/6 with the systolic augmentation in the left 4/5 intercostal space with the radiation to the right parasternal border and a low-pitched embryome at the apex.
What is the diagnosis?
So, sir, it is probably, sir, a ruptured sinus of Valsalva to the right atrium with the severe PVH, moderate pH, in sinus rhythm, in heart failure, presently in NYHA functional class 2 with no evidence of infective endocarditis.
Now you describe the murmur in left, fourth, and fifth space, right?
Yes, sir.
No, so there is no murmur in the third space or second space?
So it was best in left, fourth, fifth, sir. However, it was there from
that, but then you have to say it is heard along the left parasternal border, maximum in fourth, fifth space or whatever.
Yes, sir.
No, because your description said only fourth, fifth space. So that looks as if it is not there in the third space, which is very unlikely. You see,
Sorry.
in the diagnosis that you have made, the murmur, where is it originating from? It is originating from the
Aortic root, just above the aortic.
So
From
it
the
is
side.
originating from the aorta. There is a leak
Yes.
from the aorta. So what
Yes.
level is the aorta? What is the surface marking of aorta on the
In
on the
the
chest?
left third intercostal space at the abs area.
Yes.
Okay.
So it has to be there on the third space. It cannot be not there.
Yes, sir, it was there, sir. Yes, sir.
Okay, you
All
said you said this diagnosis RSOV to RA. You have severe PVH, and what is the reason for the PVH?
And because of the his complaint of orthopnea, sir, significant complaint of orthopnea.
No.
He's complaining of orthopnea and all is okay, but what is the physiological or pathological basis for the severe PVH?
Why should PVH occur? That's what he's asking.
Because of the large amount of shunts from the aorta to right atrium to right ventricle into the pulmonary circulation, into an unaccustomed pulmonary circulation, sir. He had.
I am asking about PVH. Then all ASDs should have PVH. Large ASD should have PVH.
So it is causing LV volume overload because the LV is of normal size and now it is receiving a large amount of blood, sir, as compared to what he is supposed to receive, sir. So there is a elevation in LV and diastolic pressure also, which causes this.
So the volume overload in rupture sinus is of which chambers?
Sir, all if it is in RA, it is a sir distal to the shunts are in all chambers. So as in our case, it is in RA. So RA, RV, LA, and LV, sir, all four chambers, sir.
Okay.
So what is
Why can't it be RSOV to RV? Why did you say RA?
Sir, because
Can it be to RV?
sir, one point is that it is because the radiation of the murmur is to the right parasternal area, sir. Second is because of the systolic augmentation, the continuous murmur was more prominent in the systole, yes, sir. These 2 points I would.
what type of shunt is?
Any other point which favors RV favors RA compared to RV?
Sir, the elevated JVP, sir, however, it can be there with RV also.
So JVP will be certainly high in RA. It will
Yes.
be definitely high in RA. Yeah, Dr. Hari Krishnan, you were saying something. Sorry.
Now, what type of shunt is the RSOV to RA? What is that? Is there any?
Left to right, sir. High pressure to low pressure, sir. Sir, what do you want to ask, sir?
No, what is obligatory shunt?
Sir, sir, it is a continuous in the systole as well as in the diastole.
No, obligatory. What is the obligatory shunt?
So obligatory shunt. What is obligatory shunt?
Do you know what is obligatory shunt?
No, sir.
Oh,
No, that's very important. You must know that.
Obligatory shunt is the one which is independent of the pulmonary vascular resistance. So like LV to RA. shunt. It will happen even if what irrespective of the pulmonary vascular resistance. Okay. Okay. So what is the next?
So just a sec. So now it is RSOV to RA according to you.
Yes.
So what do you expect in the ECG?
Sir, in case of RSOV, there is
what is the other differential diagnosis? You think this is the only diagnosis? This patient cannot have a differential diagnosis?
Sir, because of the continuous murmur, sir,
so continuous murmur. So there are lots of causes for continuous murmur. What could be the other causes? You see, I understand the history is short and there is some history of chest pain.
Yes.
So you just relating it to acute rupture. Is that correct?
Yes, sir.
So, but rupture could be chronic also. And what could be the differential diagnosis? What could be the other diagnosis? Can you tell us what are the other causes for this? For a continuous murmur like this?
Yes, sir.
So basically the continuous murmurs we group basically into the three physiologies. Either it is from the high pressure region to the low pressure region. In high pressure to low pressure, it can be either from the aorta to the pulmonary circulation, which we see usually classically in the PDA or AP window, or when there is a surgically created shunt, sir. Or it could be from the aorta draining into the right heart, which is the RSOV, or it could be the coronaries which are draining into the right heart, or the RA-RV, or it could be in the LA. So that could cause a continuous murmur, or it could be other shunts like in Lutembacher's with restrictive ASD. We can have a continuous murmur. Others would be, sir, there could be increased because of the increased flow, which could be because of the venous harm, or it could be hepatoma, or it could be Paget's disease, which would cause a, or a memory souffle, which could cause
Okay. So, okay, let's go to the ECG. What would you expect on the ECG?
Sir, we will expect LV volume overload type of.
And
along with that, in RSOV there is a left axis PR prolongation, where it can have a AV blocks or complete heart block if the aneurysm extend to the interventricular septum. And signs of RA and LA enlargement can also be there.
Do you expect LVH or biventricular hypertrophy?
Both, sir.
What do you mean?
Sir, RV is biventricular enlargement, sir.
Biventricular.
Both ventricle can enlarge. Yeah. Yes, sir.
Okay. What does it show?
Sir, it is a ECG with a normal standardization and calibration in having normal sinus rhythm, and then axis of minus 50 degree with sir a small with a QR pattern in V1 suggestive of right atrial enlargement, and although it is not showing any sign of LV volume overload, sir.
So why you are not getting the sign of LV volume load?
Sir, because of just 1.5 months of this shunt, sir. So it will take some time, sir.
X-ray?
Coming to the X-ray, sir, chest X-ray PA view, showing a fundus shadow on the left, trachea central. There is a cardiothoracic ratio of 55%, and there is an increase in the pulmonary vascularity in the upper and middle lobe of the lung, more on the left side, with a prominent.
What do you mean by increase only in upper and middle lobe? What do you mean?
The syphilization of the pulmonary vein, sir.
I see. Okay.
Yes, sir. With the Sir, slight prominence of the right descending pulmonary artery.
No, so is there increased pulmonary blood flow or not?
Yes, sir. There is. Yes, sir.
No, you
What is your evidence of, you said PVH, what is your,
Sir, the prominence in the pulmonary vessels in the upper.
no,
and
that
the
is
middle.
PVH, that is PVH. What is the evidence of increased pulmonary blood flow? Is there any evidence of increased pulmonary blood flow?
And the perihilar.
how do you diagnose increased pulmonary blood flow?
Do you have endowed vessels? Do you have dilated pulmonary arteries? Do you have cardiomegaly?
And the prominent right descending pulmonary artery is more than 17 mm. And sir, end on vessel. And the pulmonary vessel till the periphery.
With this X-ray, what shunt do you expect?
यादव जी चलेगा लगता है कहाँ
more than 2.
हेलो
Okay, go to the echo.
Sir, in this parasternal long axis view, we can see LA, LV, mitral valve, aorta, and RV with the normal LV function and normal aortic and mitral leaflets. In the color Doppler, across the mitral valve, there is no MR, and in the color Doppler at the aortic valve, there is mild AR, sir. In this parasternal short axis view, we can see LA, RA, tricuspid valve, RVOT, and the aorta and all its three cusps, and there is a defect in the non-coronary sinus with the windsock appearance and windsock appearance from non-coronary sinus to the RA just above the tricuspid septal leaflet, sir. In this color Doppler at the parasternal short axis view, we can see, sir, color flow from the non-coronary sinus of the aorta to the right atrium just above the tricuspid valve, sir. In this color compare image in the apical fourth chamber view, sir, we can see color flow turbulence from the aorta to the RA just above the tricuspid valve, sir. And there is no associated VAC, and it was also not there in the short axis view also. In this apical 5 chamber view, sir, we can see the color flow across the aorta to the RA RV, sir, just near to tricuspid leaflet, along with no significant AR, sir, and no PSD also, sir, in this view. Sir, after this, the patient was taken for angiogram, and this is a angiogram taken with the pigtail catheter in the aortic root. The catheter course is from the femoral artery to the descending thoracic aorta to the arch and ascending aorta into the aortic root. And in this RO view, the shoot was taken, which is showing filling of aorta, and along with that the flow of contrast from the aortic root to the right atrium.
Which sinus? Which sinus?
Sir, the catheter is in the right coronary sinus, sir.
No, is the catheter is the same sinus or it is leaking?
No,
it's
sir.
Different sinus.
It is in right sinus, sir. The leak is from non-coronary sinus.
From this view, you can very well say it is in a right coronary sinus.
How do you say?
LAO view would be better.
You have another view with the same position of the catheter.
Yes, sir. It's the right one, sir.
Yeah.
Sir, in this LAO view, on giving aortogram, sir, we can see a flow from the aorta down into the RA, sir, with a non-selective filling of coronaries also, sir. Both the coronaries.
Okay, forward. So what will you do?
Sir, so the diagnosis of RSOV to RA is there, sir. So the mainstay of treatment for this is surgery for surgical closure. However, a feasible alternative is percutaneous intervention, sir. With
Why do you want surgery if you can close it by device?
Yes, sir. We can, sir. There are few conditions where we
No,
cannot.
in this case, there are few conditions. What about this case?
In this case, we will do device closure, sir.
Why?
Sir, because there is no other complication like VHD or AR, and the coronary ostia are also far away from the aneurysmal site. And so.
Okay, what route will you go?
Sir,
what device will you use?
Sir, we will go from we will pass a multi-purpose catheter from the femoral artery to the descending to the ascending and then to the ascending aorta, and a thermowire will go from that multi-purpose to into the through the sinus into the right atrium, and we will keep it in SVC. And from the femoral vein, we will pass a snare, and the arteriovenous looping we form, and then from that arteriovenous looping, we will be in the direct communication from the femoral vein to the aorta, sir, in the ascending aorta, and over that we will pass a delivery sheath, and from the delivery sheath we can deliver a Amplatzer duct occluder device, sir.
Which ADO? ADO 2, ADO 1?
ADO, yes, sir.
The size of the defect, how will you measure? What is the correct approach?
Sir, fluoroscopy, sir, we can see, sir.
You have already done the angiogram. Now, where will you measure? How will you size the defect?
The size of defect will be decided by the aortic end of the sinus, sir. And the larger part of the disc size will be kept towards the aorta, sir.
Will the practice of doing a CT angio prior to angiogram is being practiced by practically all the cardiologists, which can give an exact anatomy, the size of the defect, how much away it is from the coronary?
Sir, sir, in case of confusion, sir, we can go for CT.
So you will do CT later on, or you will do CT angiogram before your diagnostic angiogram? It will save a lot of other things if you have a facility available.
Yes, sir. Prior to going for a catheter intervention, sir.
Which device you will prefer?
Sir, Amplatzer duct occluder, sir, ADO.
ADO 1 or 2? There are different ADOs. No?
One, sir.